Hi, everyone. Thank you for joining me again for another interview with an Apraxia expert. I am Laura Smith from SLP Mommy of Apraxia, and I've been hosting these virtual interviews for Apraxia Awareness Month to just get knowledge and information out there to people regarding various aspects of childhood apraxia speech. So today I'm excited to have Heather Hamilton. She's a fellow boot camper of mine, and I'm going to have her introduce herself and tell her a little bit about herself. Heather.
Hi guys, I'm Heather Hamilton. I live in Northampton, Pennsylvania, which is about an hour north of Philadelphia. I work in a couple different settings. I see some little guys through early intervention. I also have my own small private practice, and then I work in an outpatient clinic. So I see kids of all ages, along with specializing in kids with apraxia. I also see many kids with augmentative communication needs. And like Laura mentioned, we met in 2014 when we were boot camp graduates.
I can't believe it's been that long.
I know. It seems like forever ago. It's so long ago. And I'm also a walk coordinator here in the Lehigh Valley. So we are going to celebrate our 10th walk in September. So we're very excited for that.
That's so exciting. Have you been the walk coordinator all 10?
Not all 10. So I helped the first year. There was a mom who started it here. So I helped her, and then we were co-coordinators. And then when she stepped aside, I took over. So yeah.
Awesome. Thank you. All right. So today's topic is going to be about cueing primarily. We have a few other things that we're going to discuss, including precursors to actually doing therapy that we kind of need. But cueing is the main thing. One, because it's essential, but two, kids can become cue dependent and frequently do become cue dependent, and we have to fade the cues in order to get automaticity into their conversational speech. So I felt like I was telling Heather that I felt like the other day that I wasn't doing a good enough job of explaining to parents why we don't see transfer right away into conversational speech when they're seeing the child being able to do it in therapy. So I wanted to do a video on it, and you were saying that you've kind of experienced the same thing.
Yeah, most definitely. And I even see that sometimes parents say, well, in therapy, they do such a good job. And I've told parents too that I think the physical space of speech therapy or seeing me is a cue in itself. And they're like, oh, remember to do this. And they do so much better. And I said, it just kind of turns something on in their brain, and that's a cue in itself. So
that's such a good point. Yeah, they walk in your room and magically they're in like speech mode.
Right.
Yes. So the first thing let's talk about the precursors to actually doing therapy, the direct therapy needed for apraxia. Because with apraxia, especially, what's your age group, Heather, primarily?
I primarily see like preschool to like kindergarten, first grade.
Okay. And I'm preschool elementary primarily. So with that comes precursors to doing actual therapy. We're not talking the little bitties. We're not talking 2-year-olds, or that early intervention population. We're talking about when the child can do direct therapy for apraxia. There's some precursors that we actually need to be able to do that. So Heather, can you go ahead and talk about some of those?
Yeah, so one of the big things is attention. We need joint attention. The child has to be able to sit there, engage in the similar activity with us, look at my face, be able to follow cues, be able to follow commands, and things like that. I've had many kids come to me and the parents are like, oh, we've been to so many speech therapists that, we haven't seen any progress.
Thank you. Sorry, my sound goes out sometimes. Can you repeat that? You were saying joint attention.
Yeah, so the children need to have joint attention, and they have to be able to engage in an activity with me. They need to look at my face. They need to be able to follow cues, follow commands. So some of those precursors need to be taught so that they can then engage in speech practice before they can learn how to produce sounds.
Yeah, and I think it might surprise some people, at least parents, not necessarily SLPs would not be surprised by this, but it might surprise some parents to know that joint attention can be a goal of a speech therapist. So yes. Even aside from just having speech goals, it is very likely, and you should ask your speech therapist what their goals are, because it's very likely that they might have a goal around joint attention, and that would be good for you to know. Yeah.
Absolutely.
All right, good. So we have joint attention. What's another one?
Just ability to, follow commands.
Yeah.
listen to what I'm saying and be able to follow it. So their receptive language has to be up to par or at least adequate to participate in speech therapy.
Yeah, that's such a good point, that like back and forth, like I do, you do, I do, you do, like just even understanding that. So we might be working on that, you know, reciprocal play like that. And reciprocal play might be a goal, you know, before we ever get into speech. And they don't even, you know, we might, if what might look like playing to the child is an actual goal for reciprocal play or joint attention.
Right. And I often explain the reciprocal play because parents say, I just want my kid to talk. I don't want you to work on that play.
Right. No.
And I have to explain, well, conversation is reciprocal. I talk, you talk. Like you have to learn that there's turn taking there. So they have to learn through play first, whether it's rolling a ball, pushing a car back and forth. Like we have to learn back and forth before you can ever learn how to produce sounds and then use that for back and forth.
Yes, exactly. Good. All right. So let's switch gears a little bit and talk about cueing. And what is cueing? What are the different types of cueing? And why do we use them for apraxia?
So we use a couple different cueing. We want visual, tactile, verbal cueing, and they're all at different levels so that the child knows how and where to move their mouth. So I think every speech therapist has slightly different cues.
Yeah.
You know, I have my cues, you know, some are much more around the mouth, some are, you know, away from the face, some have a name, some are, you know, just a visual cue. But we need those cues because the kids have been watching our faces since they were babies and they're not picking up enough by just that. They need to know and need the help to tell their brain how and where to move. So that's why we need to use those cues. So
give me an example of a verbal cue.
Put your lips together for like a or a puh. You know, a tactile cue might be me touching their lips, or for the M sound, I run my finger across our lips, and then the child does for so they're actually feeling what their lips are doing and running their finger across them. And then what do we do? Visual. I might just put my lips together, like so that they know they have to pop their lips. So I might down, but I'm just showing them exactly what to do. And you see my hands already going for what I normally do. You know, I talk with my hands so much now that, you know, for the popping lips, it's like, you know, they see my hand go, they see my lips go. It's the same kind of movement so that they're getting those kind of cues there.
Yes. And do you have different cues for each sound?
I do. I have a different cue for each sound. And you know what? I even adapt it per kid. Because sometimes the child doesn't get what I do for most children, so I have to change it. Like one little girl, I call it the ooh lips when they need to round their lips, but for her that didn't work. I had to call it kissy lips. So they're making lips, and then she does it. But she would do it if I said ooh lips. So, you know, not only are they specific to each speech therapist, but I think they're specific to each child too, and you kind of have to ebb and flow with whatever the kid is responding to.
I can't remember which mentor told us this in boot camp, but I definitely remember it being said that the cueing that you're using isn't as important. There's no magical cue but what the magic is that there is a cue and you have to have a cue. So there's no magical cue. Everyone who sells cues or sells products, you know, they're all helpful, but the magic is not in that product. It's actually in the cueing itself.
Right.
So Yeah.
And if I could jump in too, I always have, because I certainly see children who also see another speech therapist, and parents are like, well, different cue than you do. Do you think that's going to confuse the child? And for the most part, I found kids who are accustomed to speech therapy, they kind of get it and they get in tune with their speech therapist, and they can kind of go back and forth between. If they're using a slightly different cue for an S than I'm using, they're generally okay with a different set of cues as long as they're familiar with it with that speech therapist.
Yes. I was going to go back to you saying sound like child specific cues because for the G sound, I usually have like this visual cue of my two fingers. My two fingers for me denotes voice. So I use it with voicing, but I like to use Jenny Bjorm's baby sound. She calls it like ga, 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 like for the baby sound, which I just think is funny. But I got this one girl and I was using it with her because I knew she could say a G, but I was trying to cue her that way. No go until one day I'm reading Brown Bear. What do you see? And we get to the goldfish and she was like making then animal noises for it. And goldfish was, and I was like, that was what? Like, this is what I'm trying to get you to do. So it became the fish sound. So for
Right.
that girl, it's the fish sound because that's how her brain remembered to say it. So
Right.
yeah, it's so funny how some things can just click for different kids. So
Yep.
okay, and let's see. Do you remember, like, do you also use, and so we covered, you know, kind of visual cues. Visual cues though can also be like a picture cue that you might have. The other thing I wanted to mention was verbal cues. David Hammer taught us a bunch of verbal cues. Do you use verbal cues a lot?
I do use verbal cues a lot. Because I use them all kind of, but
Yeah.
I use a lot of verbal cues just so that I can tell them, oh, remember your this sound, so that, and I can even do that beforehand and see if that's enough of a cue. Like, okay, we're going to do our blender sounds. Make sure you remember to put your lips together, and then see if that's enough of a cue that they can maintain it, or do they really need online cueing as we're going back and forth?
Yeah, I find that so effective too. Even as when we talk about, I'm getting off track talking about feedback. That's not the point of this Zoom today, but feedback is an essential component with principles of motor learning for childhood apraxia speech. And I find that having the verbal cue and the kids understanding verbal cues is great for feedback as well. So feedback is when you want to speak to feedback and how we can use verbal cues with it.
Yeah, absolutely. And like you mentioned, feedback is essential. And that's the number one thing I tell parents all the time, because as a mom, one of the things you say to your kid all the time is good job. Well, that doesn't tell them what they did and doesn't help them do it again. It just knows that mom gave them praise. So it has to be specific feedback of, oh, you put your lips here. Oh, your lips were not closed. Let's close your lips.
Yes.
So that they know what to do, because it really tells the brain, okay, I got to do that differently, or do that again. You did it right. So that feedback is really important. And, we talked about receptive language. If your receptive language isn't strong enough to understand that, then you're not going to be able to get that same result again, because you didn't understand what the verbal cue was and that feedback actually was.
Yes. So with that too, if I have a kid, let's say I have one right now who's forgetting his T on the end of words. So as a cue, instead of telling him, oh, get your tongue up and whatever, I can just say, oh, you forgot your tapping sound. Say that word again. And hopefully as a faded cue, so I don't have to use like a visual cue. Like you said, can it be enough of a cue then for them to try and plan and program plan and program the word, the movement gesture themselves to be able to get the T on the end without my help.
Right.
Yep. Which leads us to, I just said, trying to get them off my visual cues. It leads us to, maybe I don't necessarily have a cueing hierarchy. I mean, I definitely in my notes talk about max, mod, and min cues. But it's a thing. What is I guess I do have a cueing hierarchy then. That would be the definition. What's yours though? Because I had an interesting person on my Instagram tell me that she has a cueing hierarchy based on both her visual and verbal cues or tactile cues. So if she's using like all three together, it's max cues. If she's using two, it's mod cues. If she's using one, it's min cues, which I thought was an interesting way to kind of categorize it. I'm not that specific. How about you?
I'm not quite that specific. It depends on the child, but I will often write how they did it. So I don't necessarily just write max cue, min cue, or mod cue. I'll write, if they needed a tactile cue, I put a T right there in data so that I know had a tactile cue that time. If it was a complete model and they needed max cues, then, I'm writing that. So I'm more going back and forth, if we're doing 10 trials on 10 of them, how many did they need a tactile cue? How many did they, need, just a visual cue? So there's a lot of T's, V, to see, at what level are they? Did I have to do all of it in order for them to get it, or could I just do one of them?
if therapists are doing DTTC, you can do those nice denotations too. Like when I'm using like full DTTC with like a little guy who's, you know, really like just pre-verbal, and we're really in the thick of like, you know, like the DTTC does have a cueing hierarchy. And so if you're using that to fidelity, which I don't always, because I feel like I'm a blend of stuff now that I've taken a zillion trainings. But if I'm using DTTC primarily as my framework for a child, it has, you know, I denote like SP, simultaneous production,
Right.
you know, like DI, direct imitation, and then, you know, DIP, direct imitation with a pause. And yeah, so there's so many different ways, but cueing is a thing, and you have to help the child first with that cueing.
Right.
Can you talk about cue dependency though?
Yeah, so you mentioned earlier about fading the cues quickly, because kids will get dependent, and I think it's one of the hardest things, I think, as a therapist to do, is to know when I can pull back, when I can need to give them the help, because we want them to succeed as fast as they can, but at the same time we have to scaffold that and make sure that they can do it. So we do have to fade those cues quickly, and I think it's important for everyone, like you mentioned, the parents knowing when, you know, they need the cues. So if parents are watching, to know that, okay, they can do it at this level. And so that's where they are in their progress as far as cueing goes.
Yes. Yeah, because I was telling Heather before, the reason I wanted to do this video is I felt like I wasn't doing a good job explaining to my parents why the child was able to produce all of these sounds and words and everything in therapy. But when they got home, they're like, why isn't this transferring? I can correct them. And when I correct them, boom, immediately they can fix it. But why is this not transferring to conversational speech? And the why is in the bridge from the amount of cueing they need to distributing it into their conversational speech.
Right. And I think, you know, oftentimes kids do get too prompt dependent, because, you know, we have to do so many trials, and it's, you know, really figuring out when to pull back and give them less support so that they can do it on their own.
And it's a dance between all of your targets. So
Yes.
like you said, you might have them on a target where they need max cues, and you're trying to fade it off to mod, or you're trying to fade from spontaneous production to direct imitation, whatever you're doing there with one sound. But you might have another target that's ready to be generalized, and you're really expecting them to do it independently without your help at all, so that it transfers. So it's this, it really is a dance between different targets.
And I think that's important for parents to really talk to their therapist about, because,
yes,
like I mentioned, not every word is at the same level, and
yes,
every word has different level of power for the child too. So, you know, I talk to parents all the time about, well, what are your kids' friends' names? What is their favorite TV character? They might not be a word that is super easy for them. We're going to have to work a lot harder and longer on, but they really want to say it. So their motivation is higher, which might make the progress faster, but you know, so every word is going to have its own unique challenges, whether it's harder to, you know, a harder movement pattern, whether it's more motivating, whether, you know, so, you know, that progress is going to vary based on, you know, some of those factors.
And it might help, you know, for parents to be in the room. I think that, I know that you've told me before that you have most of your parents in the room, if you can. Same with me, not all of them, but most of them. And it's important for just so many reasons, but one of them being able to see that this progress in the session, you know, that they might not be seeing if they're not in with you.
Right.
So
yeah, definitely. And I think every parent should be involved, and especially if your child is seen a couple times a week, at least once at one of those sessions a week being involved, because one, you can see the progress, you can see how to cue something, you can see lots of things. And I think your child will benefit if you can carry over those skills much more at home. If you're
and not only think, we know that because of the principles of
Yes.
motor learning telling us that parents can be one of the best, you know, this is off topic too. We have so many topics that I could talk about, you know, make videos on, trying to keep this with cueing, but going off topic slightly, just to say that we have to have in principles of motor learning mass practice versus distributed practice, and mass practice is for that acquisition, but distributed practice is for the carryover and generalization, and parents can be the best facilitators of the distributed practice to get that into conversational speech.
Right. And if parents aren't in there to know, I mean, yes, we can certainly give them targets and things like that, but I think witnessing it to
Yes, it's
know
so different.
what to do and how to do it at home really will make that distributed practice much more successful.
Yes, it's so important.
And I think
So
even if I can jump in, even just ways to incorporate that, like, parents like, oh, well, I know you want me to do these words, but I don't really know how's best to do it. So I think just even, I have one family who's really great about saying, okay, he says this word all the time. How can I work this in more to get practice? So I think that's one of the best opportunities when parents are within the session so that they can ask those kinds of questions.
yes, SLPs a lot of times I hear say that, and I think it's actually, a lot of times true. The child doesn't work, as well with the parent in the room, or they become clingy, or they're distracted by their parent, or their behavior isn't as good. And what I like to say to that, if you're an SLP, that you're experiencing that with a lot of your clients, it's not that Heather and I don't. I mean, I certainly experienced that too. What I told my intern though is the bang that I get after by having the parent in there, like Heather just said, witnessing what I do, how I do, when I do it, and being able to carry that over, the progress in the long term is so much better than just me saying, I had a great 30-minute session, he was perfectly behaved, and he's on his way for the week. Like it really is. I know it seems counterintuitive because you're like, why would I not have as good as a session as I can? But the bang that you get after because the parent knows what to do, don't you find that, Heather, is so much greater?
I do. And you just mentioned 30 minutes. 30 minutes is a drop in the bucket of the week. So the parent can carry over what we just did more distributed throughout the week, then that child is going to make much more progress. And, yes, parents are like, I'm paying for this service. I want to get every minute of
Yeah.
the professional's time to be perfect, but life isn't perfect either. Every child does not come in and sit at my table and is perfectly behaved and does everything I ask them to do.
No.
I don't live in a glass house. I don't live in this world where I'm like this magical therapist that every child behaves. Like,
Right.
it doesn't happen.
No.
So, it's okay if your child's going to misbehave now and then. They're going to do it at home. They're going to do it at school. So we just have to learn how to get speech through some of that. So
yeah. And you develop a groove. You get in a groove and, you get a routine. So, trying it once and it being a disaster and kicking them out for good really isn't the answer. There is a way to do it.
yeah.
So, okay, awesome. And then last thing I want to talk about is just what is measurable progress? Parents always want to know, even therapists, I hear I hate this myth that if you have apraxia, you don't make fast progress. So in my professional hat, Laura SLP over here, I hear from therapists, or I hear from, various people that if the child has apraxia, you can expect very, very slow progress. It's very severe disorder, and it is a severe disorder. So agreed. But that doesn't mean they can't make measurable progress, which leads parents then to be confused, or as SLPs, and say, well, what is measurable progress? So
yeah. So I think it's a matter of how you're collecting data and how you're measuring what they're doing. So if you simply are looking at a test, like an articulation test, yeah, you're not going to see great progress because
right.
It's not showing you these movement patterns that they're able to accomplish now. It's not breaking it down to the syllable level and things like that. So I think it's a matter of how you're looking at progress. So like we mentioned the cueing. Well, we maybe have gone from simultaneous production where the child needed my mouth to move with theirs for every sound we were practicing or every movement pattern, to now they can do it with just me doing a visual cue and I'm not even moving my mouth necessarily. And that is huge progress.
That is huge progress.
Yes, they still not maybe be able to say that word when they're doing show and tell at preschool, right. But they can do it in simultaneous progress or I'm mixing up on it. When they can do it with a different level of cueing. So I think, we have to look at that as progress. It may not be, and that's measurable. We went from this level of cueing to this level of cueing. That is a measurable improvement on this skill. It may not be spontaneous yet, which is what all of us want, but we're still measuring that they've moved from this part on the continuum to this part of the continuum in a given amount of time.
And as an SLP, I can just say, I think that's really important to keep conveying to your parents, because I think that's one thing that I hadn't been doing very well. So it's like, we've been working on, I don't know, let's say final S for X amount of time. Why am I not seeing it in their conversational speech? You know, so to be able to explain, even if the parent doesn't ask you, to know that they might be having these questions and to explain, here's the progress that we're making. You know, like he couldn't say it at all without max cueing or simultaneous production or a tactile cue. And now he can say it with, you know, delayed feedback or just a minimal visual cue. And now we're working on trying to get carryover. So
Right. And I think to get into spontaneous production, there's a lot that has to go on. You have to remember how you're making that movement pattern. You have to self-correct if you
yes.
hear yourself. So there's a lot of pieces that go into when it actually transfers over to spontaneous production that I don't think everyone realizes.
That is such a good point with the being able to self-correct. What you just mentioned is when, for those of you who don't know, the child's listening to and monitoring their own speech enough to be able to hear that it was said wrong and go back and fix it. And not only does it take some level of cognition to do that, it takes cognition, attention, language. It takes all of those things together. And as Dave Hammer told us, you celebrate the minute you see a child self-correct and you praise it as much as you can, because when they're able to self-correct, you know you are going to make some really faster measurable progress because they're being their own little speech teacher outside of your office.
Yep, absolutely.
Yeah. So, okay. Well, is there anything else that you wanted to mention regarding the topic of cueing?
I don't think so. I think we covered it. I think it's just make sure if you're a parent, you're asking your speech pathologist, what level of cueing are you using, and knowing what that is. I think as parents, you have a right to ask any question about what's going on and how to best help your child. So just be as educated as you can about it.
Perfect. Well, thanks, Heather, for coming on and doing this with me. It's so fun to talk to you.
Yes, and you too.
All right. So thank you, everyone. Bye.
Bye.